We are live.
Good evening, everyone. I welcome you all to today's iFocus online lecture number 471. Currently, we're running in the 22nd refractive module. Today, we have Dr. Sheetal ma'am. She's a medical director of ProSight Laser Eye Hospital, Chandigarh. She's going to teach us about Kerato-Lenticule extraction procedures and overview of smile, silk, and clear procedures. Welcome, ma'am.
Thank you. Thank you so much.
We have Dr. Shreya Tyagi ma'am to moderate today's class. Ma'am has finished MS Ophthalmology with a gold medal from Gandhi Medical College, Bhopal, after which she did a FICO. She has finished a fellowship in Cornea and Cataract Department from Shroff Charity Eye Hospital, Daryaganj. She's trained in refractive surgery under Dr. Rupal Shah ma'am. She's been a survey doctor in rapid assessment of avoidable blindness 7. Currently, she's a consultant at Center for Sight Eye Hospital, Ghaziabad. She's performed more than 3,000 cataract surgery procedures, including complicated cataracts. She has trained many fellows in cataract and penetrating keratoplasty surgeries as well. Ma'am has numerous presentations and publications in prestigious national and international conferences and journals. Welcome, ma'am, and over to you for the introduction of our chairperson, the mother of Smile, Dr. Rupal Shah, ma'am, and our speaker, Dr. Sheetal, ma'am.
Thank you so much for the introduction, Pratika. It's a pleasure to introduce ma'am, Dr. Rupal Shah ma'am. She has been a refractive surgeon since 1994 and fondly described as the mother of smile, and rightly so. She is the first person in the world to do one incision smile, first in the world to use circle software in a patient for retreatment in smile. Ma'am has surgeons from across the world. As a pioneer in LASIK technique, she has performed more than 50,000 procedures. Currently, ma'am is the medical director of New Vision Laser Center for Sight, Vadodara, Gujarat. Last month, she successfully conducted the 77th intensive LASIK training course, which is attended by more than 20 ophthalmologists. Ma'am has many national and international publications and presentations. She has numerous chapters, prefaces, and introductions in several prestigious international books. She is also a recipient of numerous awards and gold medals. It's a pleasure to welcome you, ma'am. Moving on to the speaker for today, Dr. Sheetal Brar, ma'am. Ma'am is the medical director of ProSight Eye Hospital, Chandigarh. She has trained more than 200 trainees in phacoemulsification and complex cataract surgeries and more than 100 surgeons in refractive surgery. She's participated in over 100 master classes and instructional courses and performed live surgeries of phacoemulsification and smile. She has more than 100 publications in national and international peer-reviewed index journals. She has been a reviewer for Journal of Refractive Surgery, Cornea, JCRS, BMC Ophthalmology, Open Journal of Ophthalmology, and IGO journals. She's a receiver of over 30 international film festivals and Best Papers of Session awards. She's also the first woman ophthalmologist from India to receive the prestigious APA-CRS Certified Educator Award. We welcome you, ma'am. Over to you.
Thank you so much, Dr. Shreya, for the generous introduction. And I would like to thank Mahipal sir and Honawar sir for this kind invitation and opportunity to speak on a topic which is very close to my heart, kerato-lenticule extraction procedures and KLEX as we call them now. And it's a great pleasure to be speaking on this topic in front of no other than Dr. Rupal Shah ma'am. And she, as we all know, is the mother of Smile and has contributed richly to this field. So it's a great honor and pleasure, ma'am, to be presenting this topic in your presence. So thank you so much. So shall I share my slides?
Yes, ma'am.
Thanks, Sheetal and Shreya. Yes. Move forward.
Thank you, ma'am.
Really
Okay.
forward.
Is my voice fine?
Yes, ma'am.
Okay. So, good evening, everyone. So, I'll be talking about kerato-refractive lenticule extraction or KLEX, and I'll be giving an overview of the currently available technologies for. So, I'm a consultant to Carl Zeiss Meditech, Germany. However, I have no financial interest in the subject matter of this presentation. And I have few acknowledgements to make. Professor Walter Secundo from Philipps University of Marburg, Germany, Dr. Raghav Malik from CFS, New Delhi, and Dr. Nitin Deshpande, Director Shri Ramakrishna Narayana from Thane. I have the presentation is not entirely mine. Of course, I have experience with the Zeiss platform. However, I have asked for help from my colleagues to help me with some material for regarding the other platforms which are available. So thank you so much, Dr. Walter Secundo, Dr. Raghav, and Dr. Nitin Deshpande. So let's go to our topic. So these are some historical landmarks, and you can see some photos how evolution of smile. It started 20 years ago with the beginning of in vivo research in Jena, Germany, and you can see that we have some of the pioneers of smile, Professor Bloom, Mark Bischoff, and Walter Secundo, and they were the pioneers of lenticule extraction technology, and our own Dr. Rupal Shah ma'am, who showed us how to do a lenticule extraction surgery using a single access incision. And the small incision that we are using today also was her big contribution to this field. So as of today, we have more than 10,000 more than 10 million procedures of smile that have been performed all over the world. And with the addition of new lenticule platforms, I'm sure this number is even higher. So in the simple form, if we understand what a KLX procedure is, it is basically a minimally invasive procedure wherein without cutting a corneal flap, we create a femto laser creates a complete lenticule and an access incision in one step. The surgeon then manually separates this lenticule and then extracts this through a small incision. So KLX has certain advantages over the LASIK or other conventional procedures like PRK and LASIK. So of course it is flapless, and so we are not creating any flap. It is done through a small incision rather than a full flap. It is an all femtosecond laser procedure wherein the femtosecond laser is used to cut a refractive lenticule in the cornea that substitutes for the excimer tissue ablation. It's a single step procedure wherein a single laser does the entire procedure. So you don't have to use a femto laser or a blade to first cut a corneal flap and then shift the patient under an excimer for ablation. So this is a single step, so also a time saving. It is less dependent on ambient conditions, and it conserves corneal nerves and induces less dry eye because we are not cutting a corneal flap there. And it has been shown in peer-reviewed publications to have superior refractive predictability and stability of refraction over time, especially in higher myopia. And since we are not making any flap, we avoid all the flap-related complications. And possibly we also have a biomechanically stronger cornea compared to a excimer laser procedure when treated for the same power. However, this is something which still needs more research. Now, Visomax 500 and 800 are the two lasers from Carl Zeiss Meditech, and Carl Zeiss Meditech was the first company to come up with this idea of lenticule extraction, and 20 years ago this started in Germany. And as of today, we have 1900 devices of Visomax 500 which are installed, and over 800 publications supporting the safety and efficacy of smile procedure. So the lenticule procedure performed using the Visomax lasers is called SMILE. With the 500, it's called SMILE, and with the 800, it is called SMILE Pro. So as of today, there are 100 devices all over the world which are installed and of SMILE Pro, and there are a couple of publications as well. So this is the evolution of the SMILE procedure and the laser. It started from a a slow laser of 200 kilohertz frequency, and then it was upgraded to Visumax 500 with a 500 kilohertz frequency, and then today we have a much faster version of this, which is the Visumax 800 with a 2 megahertz laser frequency. So when we increase the frequency of the laser, this helps to reduce the treatment time. So because of this fast repetition rate or the frequency, the treatment time or the laser, the lenticule cutting time has come down from almost 27 seconds to 8 to 9 seconds. So when we compare the features of Visumax 500 versus the 800, the working principle remains the same, which means the lenticule extraction is pretty much the same. However, the scanning pattern is faster with a higher repetition rate of 2 megahertz. It has these swiveling arms for laser and operation. So when the laser arm is down, then it creates the lenticule. And once this is done, then the laser arm goes up and the operating arm comes down. So the surgeon is, which has the microscope on it, and this is used for extracting the lenticule. The docking in this laser is done by device movement, which means the bed of the patient does not move, which makes it more comfortable for the patient. It also has some surgeon assistant functions such as central line and oculine that help in better centration and better cyclotorsional control for astigmatism eyes. And it also has digital connectivity and refractive workplace for improved workflow. Now, in 2023, a new term called KLEX or Kerato-Lenticule extraction was introduced, and there was a need for this because different companies were coming up with their lenticule platforms, and they were giving different names to the procedures. So this is why, and this was creating confusion amongst surgeons as well as patients. So it was decided that a common term is given, and this was KLEX. So all these lenticule extraction procedures now come under the umbrella of KLEX, which are essentially work on the same principle, which is lenticule extraction. So at the end of 2024, we have 4 companies or 4 types of KLEX procedures, which are promoted by different companies. So we have Smile and Smile Pro by Carl Zeiss Meditech, wherein over 10 million procedures have been done. Smart Sight from Schwind, over 20,000 procedures done. Clear by Zimmer, also over 20,000 procedures done, and Silk by Johnson & Johnson's, where several hundred procedures have been performed worldwide. All platforms have different operating principles and equipment with certain advantages and limitations, which we will discuss as we go along. So the intended use of most of these technologies is essentially is the same. So with all of these, you can correct up to -10 sphere and -5 cylinder, except for the J&J Elita, which allows cylindrical correction up to -6. So with all, you can correct a maximum MRSC of -12.5, and with Elita, the maximum MRSC which can be corrected is -13. So this is a essential shape of a lenticule in KLEX procedures. So you have a lenticule cut, which is the underside of the lenticule. And then you have the lenticule side cut. And then you have the cap cut. This is the cap cut. And then you have a incision, which is the access incision through which you separate and remove the lenticule. So this is a basic form or geometry of the lenticule. Different companies have made some modifications in the lenticule geometry also, which we will be discussing. So regarding the technical data, this is a busy slide, but I would just touch upon the different the differences in the suction type and the pulse energy and various energy parameters. So for Visumax, the Visumax 500 and the Visumax 800 from Zeiss, the suction type is conial. With the Z8 or Zemer, it is scleral. With Atos, it is again corneal, and with Alita, it is again scleral. The optical system is full field with the Visumax lasers, whereas with the other platforms, it is partial field. So let's talk about this. Um, let's also discuss this scanning time for lenticule. As you can see, the scanning time or the time taken to create the lenticule is shortest for Visumax 800, which is under 10 seconds. And when we look at the suction duration, it is also shortest with the Visumax 800, just about 15 seconds, and it is highest with Z8 and Atos platforms, going up to 75 to 95 seconds. Now, full field versus partial field optics. So Visumax optics are full field, and the other platforms have partial field optics. Now, what does it mean? So full field objective lenses by Zeiss basically have large optic aperture, which can address the entire treatment field without moving their laser objective. So because of the high numerical aperture, this is expensive and also mechanically larger, so larger in size, which can present sometimes limitations when confronted with patient's anatomy, like big nose or cheekbone. When we come to partial objective field objectives, which is there in Zemer, Atos, and Elita, these can only address a small part of the actual treatment field without moving the objective. And they are comparatively small in size and are less costly to produce. However, this advantage of the cost is offset by certain limitations and the additional effort which is incurred when it comes to creating the cutting surface, which means that the lenticule cutting, these objectives are a little slower at lenticule cutting. So these are the differences between full field and partial field. And now coming to applanation surface, applanating interface and suction. As we discussed with the Visumax 500 and 800, and also Schwind Atos, the applanating surface is curved. So when you use a curved applanation surface, it actually leads to less distortion of the cornea. With the Zemer, Femto LDV and Elita, it is flat applanation surface. So when you use a curved interface, it leads to low deformation of the corneal tissue and less IOP rise, because of which the patient does not really have any blackout at the time of suction. Patients do not feel any pain or discomfort, and they are able to see the fixation light throughout. So this is the advantage of the curved interface. And there is no corneal distortion, no corneal folds. There is no shifting of the pupil. So you get also a better centration. And it is also suitable for small palpable fissures. Now, we all know the mechanism of action, how femtosecond lasers work. So basically, they work on the principle of photo disruption. And this is very important to understand how photo disruption happens. And we have basically two types of femto lasers: high pulse energy and low pulse frequency lasers, wherein the cutting process is driven by the bubbles. And we, on the other hand, we have low pulse energy and high pulse frequency lasers. These are the lasers which are nowadays preferred. And here the cutting process is basically driven by the focal spot size. Now, if you want to understand what I just said, basically in a femto laser, you have the femto pulses which hit the cornea, and when they hit the cornea, they have a spot size, so they just disrupt a part of the tissue, and this then expands as plasma. And as new pulses are placed next to each other, so it creates a shock wave and a cavitation bubble that basically results in a resection plane. So in the first type of laser, which is the high pulse energy, you need the pulse energy itself is high. So this leads to a bigger plasma, and hence you can basically these lasers have low frequency, which means the speed of the laser is slower. But since you have a bigger spot size and you also have a bigger plasma, it disrupts a bigger part of the tissue, and hence basically the cutting process is mainly driven by the bubbles. But here you have a high pulse energy. So high pulse energy can basically lead to more tissue distortion, and also things like DLK and slower visual recovery. So these systems are not very popular now. So now we basically have most of our systems are low pulse energy, wherein you have every pulse which has a low energy, smaller spot spacing, and high pulse frequency. So you have a fast laser that basically fires the pulses at a very fast rate, and the spot is very small. Energy per pulse is very small, so you need lots of these pulses and spots very close to each other, and this is going to give you much more smoother resection plane. So you can see here the tissue distortion is more with a high energy system, and with a low energy system with smaller spots being placed very close to each other, this plane is much more smoother. So but what we need to understand is that when we look at our clinical outcomes and performance of lasers, it does not depend only on one parameter. That's, let's say, a pulse energy or repetition rate. So it's not that always a laser with a very high repetition rate is always the best. So it is not about one parameter. You have to look at all the parameters, and basically it's a very complex interrelationship of laser parameters such as pulse energy, repetition rate, focusing power, pulse duration, the spot shape, wavelength, etc., etc., that actually cannot be compared on a simple one parameter basis. So if you change one thing, you will also need to also change other things. So basically, when we talk about energy and spot spacing, if we want to achieve smoother cuts and minimize collateral damage, what we need to have is basically tighter spot spacing, which means the spot spacing has to be lesser. The frequency or repetition rate needs to be high, and the pulse energy should be low. So these are the preferred parameters which will be beneficial. So when we compare the current femtolaser platforms for lenticule extraction, with regard to the repetition rate, what you can see here is I have already highlighted the important ones. The Zemer or the femto LDV has the highest repetition rate in the range of 20 megahertz. Okay, so others are Visumax 800 is 2 megahertz, the Schwind et al. Is 4 megahertz, and J&J Lita is 10 megahertz. So with the Zemer, it's about 20 megahertz, so it's the fastest repetition rate. Pulse duration is within the ranges of 200 to, let's say, 580 femtoseconds. But with the J&J Elita, the duration seems to be the shortest, from 100 to 250 femtoseconds. The energy per pulse, again, with the Zemer platform is the least, which is less than 60 nanojoules. Whereas with the Zeiss platforms, it's between the range of 110 to 200 nanojoules. With the Schwind, it is 75 to 135 nanojoules. With the Elita, it is 60 to 200 nanojoules. But with the Zemer, it's the least. The spot spacing also, if you see, the Zemer and Elita have the smallest spot of 1 micron and less than 1 micron, less than 2 micron. With the Schwind, it is between 4 to 5. With the Zeiss platforms, it is 3 microns. And the spot spacing with the Zeiss platforms, it can be varied from 1 to 4.5 microns. With the Zemer, you have the overlapping spot spacing. With the Schwind et al., it is between 2.5 to 5. And with the J&J Lita, it is again 1 micron. So, as I said, energy optimization is not such a simple thing that we just change one parameter and we optimize the energy. It's basically a constant process. And it is also important to note that minimizing or maximizing a single parameter will not necessarily lead to improved clinical results. And so, as I said, it's an interplay of different parameters, and you need to make changes into all parameters to get that perfect sweet spot of the energy where your bubble pattern is perfect and there are no black spots, there are no OBLs, there are no tissue bridges. So this is a process that goes on continuously as you do more eyes. And you need at least 50 to 100 eyes to basically optimize your laser settings. Inter-device comparison on isolated parameters is not conclusive, and it is ideal to do a comparison of macroscopic aspects of the entire laser process, which would be more conclusive from a user perspective. So when we say macroscopic aspect, it just means that uh, how your laser is performing, what kind of a bubble pattern are you getting, is the dissection smooth. So look at these aspects rather than just looking at one parameter like energy or spot spacing. So centration again is an important topic, and most of our lasers ensure that the treatment is centered on the visual axis or corneal vertex. So with the Visumax 500, it was the centration was basically achieved by patient-controlled fixation onto a green light. With the 800, now this is guided using a centra-aligned function before docking. And with the Schwind Etos also it is guided before docking. With the Zimmer and J&J, basically it's manual. So after you dock, then because these are flat, they have flat applanation surfaces. So after docking, there can be some amount of vertex shift or corneal pupil shift. So the surgeon might have to do a certain adjustment of the pattern manually. So this is just a small video to show the central line function. So you just need to basically center a vector into the yellow circle that ensures the centration of treatment within 200 microns. This is available with the Visumax 800 platform. Now, cyclotorsion control is again something important for eyes with high cylinder. So with the Visumax 500, this was completely manual, wherein we had to first mark the 180 degree with the ink and then match this with the reticule of the eyepiece in the in the microscope. And then if there was a rotation, we had to do a manual adjustment of it. With the Visumax 800, this is now automatic, and there is this oculine function wherein you also do a preoperative IUL master. The IUL master captures the iris image of the patient, and this is then transferred to the laser on the day of surgery. And when the patient lies down, this basically matches the iris pattern and compensates for the cyclotorsion automatically. And with the Schwind Etos, it is also automatic based on the Paramis, which is the topographer and abrometer linked with this. With the Zimmer and J&J Lita, it is still manual, wherein you have to use the ink marks and then compensate for the cyclorotation manually. So this is just a video to show the docking of the Visumax 800 and also showing the central line and the oculine features. So docking is quite simple. You just move the laser towards the patient's eye, and once 80 to 90% suction is applanation is achieved, you press the suction. So here, you can see there is this vector which needs to be placed in this blue circle, which shows centration within 50 microns. And this is the cyclotorsion compensation using the oculine feature, where you can see that there is 4 degrees of cyclotorsion which the laser has compensated. And once this is done, then you can go ahead with the laser firing. And this is the lenticule being created within just 8 seconds. So this is very comfortable for the patient because it's a corneal suction. And this is the surgical video of just to show the dissection, that it's quite smooth with Visumax 800. So you can see here, there's no OBL or black spots. And this is a low myopia patient and a thin lenticule being dissected. You can see that it was quite smooth. And these thin lenticules I like to stain and check for any loss of tissue in the periphery. So coming to the ELITA system, wherein this enables silk. Silk is small incision lenticule keratomiliosis. So the new femtolaser ELITA was designed for flapless refractive correction via lenticule removal for myopia. Basically, this machine delivers low energy treatment through a combination of ultra short pulse duration, ultra fast pulse frequency, and small spot size, which results in creation of very fast and smooth cuts for easy lenticule removal and symmetrical anterior and posterior lenticule surfaces. So it has differentiated its technology by incorporating ultra precise pulse, and this short pulse treatment is within the range of 150 femtoseconds. The spot size is just 1 micron, and the energy per pulse is very low, just 40 to 50 nanojoules, which ensures very less tissue disruption for better visual outcomes. It also ensures continuous surface scanning with ultra fast delivery because the laser is very fast. So it is 10 megahertz. And this is a very fast frequency, and it results in contiguous spots. So basically, the spot spacing is just 1 micron. So the spot separation is just 1 micron. So the spots are placed very close to each other so that there are no tissue bridges, and it results in free dissection. It leads to easy lenticule removal and flaplets for better visual outcomes. And it also has the proprietary first biconvex shaped lenticule, wherein basically they say that it retains more corneal cap periphery, and it matches the surface because our cornea is convex anteriorly. So in a plano-convex shape, which is or the meniscus shape of the Zeiss lenticule, compared to that, they claim that the biconvex shape matches the surface better, and it also results in robust lenticule edge because you can see that the edge is basically there is a transition zone here, and it results in better biomechanics. So less corneal folds in Bowman's layer, more residual anterior stroma in the periphery because of this shape. Because of this shape, you can see that you get more anterior stroma in the peripheral part, which probably can contribute to better corneal biomechanics. The edge of the lenticule also is supposed to be stronger. That could minimize tissue tears at the time of lenticule extraction. And probably they say that it also results in less higher order abrasions and more preservation of the corneal nerves and faster regeneration of the corneal nerves. So so still these are the claims, and we still need to see more data and clinical studies basically to see if these claims are beneficial for the patients. So this is a procedure of silk being performed. This is the docking part, courtesy Dr. Raghav. Thank you for this video. So you can see that the docking is being done. So what you do here is that it's actually quite similar to intralace. So you have the suction ring, which is being placed on the patient's cornea, and then the suction is applied. So it's a two-step docking. And then the gantry of the laser is brought down, which has the patient interface. The patient interface then fits into it. and then this docking is completed. So once the docking is done, then you can see on the right screen video also the docking and application of the suction ring. So vacuum is applied. And once the suction is in the dock is in the green zone, then the vacuum is applied and then it is locked. And once it is locked, then here you can see that they are adjusting the corneal marks basically for cyclotorsion compensation. So this was the manual cyclotorsion compensation being done for the cylindrical power. And now you can see that this is the scanning pattern. And this is the lenticule being formed. So it typically takes 15 to 16 seconds with this platform for creation of the lenticule. And the surgery per se is similar to smile surgery. So you separate the anterior and posterior planes. And you can see a little bit of subconj hemorrhage here. That's because the suction pressure used in this platform is comparatively higher. However, when you are seeing the dissection, it seems to be quite smooth. Because as you can see here, sir is not stabilizing the eye also with the forceps. And he's able to dissect the lenticule quite smoothly and easily without much effort. So this definitely shows that it's an easy dissection. And this is how this is being done, and it looks like it's quite a smooth dissection and experience for the surgeon. So coming to Schwind-Ertos or Smart Sight, this is the name of the procedure. So it has 4 megahertz laser repetition rate and intelligent eye tracking and cyclotorsion compensation. So basically what it means is that it has this semi-automated centration of the patient eye, automated pupil recognition, and objective treatment offset. Cyclotorsion compensation during docking procedure is based on the data from Schwind diagnostic devices like Cirrus. So this allows for automated cyclotorsion compensation as well as centration. And they also say that it is tissue saving through improved lenticular geometry. So basically here they have eliminated the minimum lenticule thickness which is there in the Zeiss lenticule. So here they have added a transition zone, but they have removed the minimum lenticule thickness. So because of which basically you save some amount of tissue. So this is about the Schwind platform. And coming to the Clear, which is with the Zimmer Femto LDV Z8 platform. This is a very light and compact laser platform. So with the Zimmer, it applies laser pulses at high frequencies of up to 20 megahertz. So this is the fastest frequency we have. And the spots are basically put on in a overlapping manner. So what they say is that there is no spot separation at all. So the spot size itself is less than 2 microns and these spots are overlapping. So they are eliminating any tissue bridges which could even occur because of the spot separation. So it results in reduction of pulse energy. Of course, when you bring the spot so close or if they are overlapping, you have to have very, very low pulse energy. And this is what this platform gives you. Its pulse energy is less than 60 nanojoules per pulse. The docking in this system is essentially done using handheld laser applicator, wherein you can do a one-step or a two-step docking. As you can see here, this is a handheld laser applicator which is being directly applied on the eye of the patient. And other than these features, it also has a special feature that it has guiding tunnels. So sometimes as a beginner, you're not very sure which plane you are in. So you need to separate the anterior plane and the posterior plane. So with this platform, they also provide guiding tunnels to anterior and posterior plane so that it is easy for the surgeon to identify these planes. It also has compensation for cyclotorsion, but of course this is not automatic, it is manual. So you mark the cornea, and then after the suction you can compensate for cyclotorsion. It also has different centration options, pupil center, fixation light, corneal marking. It also has flexible incision placement, so you can create two incisions basically, and second incision can be a rescue incision in case you have problems with the first incision. So the second and so the centration and cyclotorsion compensation, basically with this system, you mark the cornea in the horizontal and vertical axis through the first Purkinje image. So once you do this marking, then when the patient lies down, you look for the movement of these marks. So if these marks have rotated, then basically you have to do a second marking also in any case, because this is needed for centration. If there is a rotation of these marks, then in the same direction you can place the second marks using the Awad 3 marker, and this basically has to be done under the microscope. Now this marker actually has longer blades, and because of these blades sometimes you can have corneal defects or epithelial defects. So this is something that you need to watch for. Another advantage of this system is that it has a perioperative OCT imaging system. So if there are any issues with the centration of the dog, or there are any black spots, anything between the cornea and the applanating surface, this can be seen through the OCT. So another method is you mark the horizontal axis and the vertical axis, and instead of using the Awad marker, you just extend the corneal marks under the surgical microscope, basically using a hockey epithelium removal knife. So just this is the last part. So the Visumax, looking at the results, the published results of these platforms with the Visumax 800 Smile Pro, this was a study by Professor Dan Reinstein, wherein they looked at the efficacy and safety. So what they found was that at 3 months, there were 76% eyes with no change, 15% eyes with gain in one line, and 8% eyes with loss of one line of CDVA. And the efficacy, if you see the cumulative Snellen's vision chart, 90%, 91% eyes saw 20/20 or better, and 50% eyes saw 20/16 or better at the end of 3 months. This was a multicentric study with Visumax 800, wherein there were around 300 eyes. And at 6 months post-op, there were 93.2% eyes see UDBA of 20/20 or better. Now, when you compare these results with CLEAR, this is one publication by Awad et al., wherein they reported that the post-op UDBA, there were 97% eyes seeing 20/20 or better at 6 months, and about 8% eyes having loss of one line or better. So this is a bit similar to the results of Smile Pro. With Silk, these are results from Dr. Mahipal and Dr. Rohit Chetty's group, and they have published that at the end of 6 months, 96% eyes were seeing 20/20 or better, and 63% eyes saw 20/16 or better. This is at 6 months. And there was no eye that had loss of CDVA, and there were 40% eyes with no change and 48% eyes having gain in one line. So Now, I've just prepared these slides just to give you basically the strengths and limitations of each of these systems. So with the Visumax 800, the Smile Pro, the strengths I feel is the biggest strength is the shortest treatment time, less than 10 seconds. Its central line guide for better centration, automated cyclotorsional compensation with the Oculine. It has a retreatment option, which is the Circle software. If suction loss happens, it has a restart mode which is available. Laser cut, this is the only platform, by the way, wherein you can actually see the laser cut happening on the cornea while the laser is delivering. And no other platform actually you can see this, but this actually shows you the real time laser tissue interaction happening on the cornea. It also has a hyperopia treatment which is available. Now it just got CE approved. It has inbuilt slit lamp and also digital connectivity. And since over 10 million eyes have been treated with over 800 peer-reviewed publications, so this is, of course, a system which is time-tested. The limitations, I would say, is its higher cost, comparatively higher cost compared to the other platforms, and it's extremely gentle suction, wherein patients could have a suction loss, but with the 800, I have never experienced any patient having suction loss. One thing that probably can be slightly improved here is that if the energy patterns and the spot spacing patterns can be worked out in such a way that the lenticule becomes a little more smooth and maybe free floating. I would say this can be could be an ideal platform then. About the other platforms, the Silk, strengths would be its high repetition rate, that is 10 megahertz, 1 micron spot size, and its first biconvex lenticule shape, which of course has still very less clinical data available. Limitations probably could be a two-piece PI, two-stage suction like intralase, a higher suction time, higher degrees of suction. Surgeon is not able to see the laser cut during the laser. There is no inbuilt microscope, and retreatment options are not yet available. With the Clear, it's a very light, compact mobile system. It's 2 micron spot size, overlapping spots, and lowest pulse energy, which ensure a smooth cut would be its biggest strength, I would say. Patient's bed does not move, and there is also a perioperative OCT which is available. Limitations would be it has a handheld docking device which I feel is a little cumbersome to use. Manual centration after docking and suction, again, sometimes there could be errors when you're doing it manually. Ink-based manual cyclotorsion compensation after suction. Again, surgeon is not able to see the laser cut during the laser. So if you are getting a big black spot or insufficient laser delivery, that is not really visible. No microscope and retreatment options not available. With the Smart Sight, strength is again, it's very small spot size, 4 megahertz frequency, very fast. Digital connectivity with Sirius and also MS39, and an eye tracker and automated cyclotorsion compensation that ensure very good cylindrical corrections. Limitations, laser preparation time apparently is very high, about 90 minutes. Suction time is also high, 1 minute, and it also has a higher suction pressure. It has one treatment pack size as of now, which is not suitable for all the eyes. No restart mode available, and not able to again see the laser cut during the laser, and no inbuilt microscope. So finally, some take-home points here. So the world of refractive lenticule extraction is undergoing drastic changes, and we now have many options in the field of lenticule extraction available today. More providers to choose from. All of them rather, showing good results for myopia and myopic astigmatism, at least in the first 6 months data that have been published. The current platforms have now been upgraded, and the upcoming ones are also on horizon. So this is quite exciting. These updates have certainly definitely attracted more surgeons to shift to lenticle-based procedures. So the trend has been changing with the advent of new lenticle technologies, which have so much to offer for surgeons and patients. More and more surgeons are now shifting to lenticle-based procedures, and also with the results being very comparable to flap-based procedures in terms of safety, efficacy, lack of flap-related complications, refractive lenticle extractions is definitely here to stay. So thank you so much for your kind attention, and we can have a discussion now.
Thank you so much,
Can
ma'am.
I?
It was a wonderful presentation. You have included everything possible, and we are left with very less questions per se. But ma'am, we just wanted to know what.
I tried to include everything, but I hope it was not too overwhelming.
No, ma'am, it was not, because it was so well prepared and the points were so well aligned that we could follow it very well.
Sheetal, this
Thank
was
you.
as expected from you, from the great experience that you have for years, and the efforts that you put in everything that you do. This was really expected, and you really lived to the expectation. You were very good. It covered almost entirely everything. I have just one small question. What do you think
Thank you.
that is the world going to do only lenticle extraction procedures, or the older ones will still survive?
I think older ones will still survive because we do not have all the uh, available treatments. Like retreatments are still not possible with the lenticle extraction technologies. We still need eximers for retreatments. So even for smile, if we want to do retreatment, we either opt for a PRK or a circle. So I think it's still time until we discard our eximers. We will still
Also,
need them,
Sheetal, I
and
would like to
certainly
know.
also procedures like
Yes.
yes, ma'am.
Yes, please go ahead. Sorry. Go ahead.
No, ma'am. You were saying something.
No, no, please, you
Yeah,
finish
so I
your
was saying that we will,
explanation.
yeah, need. And still, we need topo guided treatments. So topography guided treatments are yet not available with lenticule extraction technologies, and wavefront guided also. So I think the technologies still need to improve, and we ideally should have, because there's also a learning curve which is involved with the lenticule procedures. A surgeon who is transitioning from excimer based procedures to lenticules, so definitely goes through a rather steeper learning curve, and there can be complications like lenticules being removed incompletely, torn lenticules and things like that. So again, we will need flaps and topo-guided treatments to correct these kind of complications.
So I totally agree with you. I would also want to ask whether you find that is there any specific case where you would not want to do a lenticle extraction? If everything else is fine, if your cornea is okay,
I
but
still
are there any cases where you would not opt for lenticle extractions?
I'm a big proponent of smile and lenticle extraction. So wherever it would be possible, I would like to do lenticle-based procedure if everything is fine. Unless it's patient's choice
Yeah.
or economical reasons. If it's my choice, I would like to do lenticle extraction always.
Yeah.
Because
If
of
there
the
are
obvious advantages we know,
opacities
no
on the cornea which
de-epithelialization,
are superficial,
no flap.
if there
Yes,
are
yes, of
superficial
course.
opacities, that probably would be a limiting factor if it is too dense, because the femtosecond laser will not be able to go through. So that I think would be one limitation. And secondly, if there is already a procedure done on the cornea, then probably it would not be a good idea to go with a femtosecond laser then, unless you can exactly make out where the flaps are, of the original one. Also, I wanted to know whether pure cylinders do well at each and every one of these platforms.
In my experience, I have treated up to 4.5 diopters cylinders with SMILE with manual marking, and have found good results. But with time, I think by 6 months or 1 year, there is certainly some amount of regression which is seen. So I think high cylinders again. Now, of course, I'm yet to use the Centra, the Oculine, the automated feature, and I want to see its results in high cylinders. But I think
But that is
examiners
going to be the limitation in any cornea, any
fare very
procedure,
well with
because
high
cornea
cylinders.
may not modulate to that extent. So
Yes,
that is
ma'am.
going to be a limiting feature in any platform. But some of the platforms do offer pure
Yes, ma'am.
cylindrical error treatments, while some like the 500, you need to put in a little sphere at least in the myopic range to be able to do a cylindrical error
Yes, ma'am.
treatment.
Yes.
So there are limitations to that,
Yes,
but
ma'am.
again, not
We
a
need
big
to put
one. And
0.5,
for
at least a 0.5.
yes,
Yes, ma'am.
yes. So most of the cases today can be easily be done by lenticular extraction. And beyond the limits that are available in almost all platforms, on the cornea, we should not be going beyond those limits in any case, because the induced aberrations would be too high. So I think there is some sense in what the company people have also devised. It's not as if you can't treat up to 14 and that they couldn't have done that. In fact, when I was doing the SMILE study, they had given me a laser which could go even up to minus 14 diopters with any combination. But I think that there is a limit that the cornea also offers, and therefore we should all be limiting ourselves and not be overzealous. I know that in olden times, people have even treated up to minus 18 and 20 and boasted about it. But I'm sure that they had also burned their fingers after that. So that is, I think, something that we all need to know, that there are limitations to each and every techniques. And if we understand and stay within the limits, then each one can work really well for us. But this is a very good addition to our armamentarium as refractive surgeons. And you really very well pointed out the each and every platforms and beautifully described the whole thing and also the physics of it. So thank you very much, Sheetal. This was really a treat.
Thank you
Shreya,
for the
over to
kind
you.
words and for the encouragement.
ma'am.
Still learning a lot.
I wanted to ask, like in the cylindrical powers more than 3.5, and when we have a cornea around 510 or 500 micrometers, so is it that the flap-based procedures are a better option as compared to the lenticule-based ones?
No, up to 3.5. If you have a 0.5 cylinder also, it's okay to do a lenticular extraction.
More than minus 3.5 cylindrical.
Up to 5 I've done. And it
Okay.
really gives very stable results as
Yeah,
compared to LASIK.
Yeah.
But
Okay.
you do need a little sphere, a minus 0.5 with it.
Okay.
It cannot be a pure cylinder,
And ma'am,
at least on the Zeiss platform.
then the debate comes of
So I can just add to this.
yes, ma'am.
In these cases, Dr. Shreya, you asked, no, when there is a pure cylinder
Yes, ma'am.
and no sphere, let's. So
Mhm.
if it's a young patient, so I check them with a plus 0.5 sphere.
Okay.
So if the patient is accepting a little plus 0.5, so you can add a minus 0.5 sphere, because young patients can accommodate well And as it is also, we kind of slightly overcorrect them.
Mm.
So if with these high cylinders, if there is no sphere at all, you can just check if the patient accepts a little plus. So maximum up to 0.5. And if he accepts, then you can add a minus 0.5. So then it will allow you to do.
Okay, ma'am. And ma'am, then the debate comes of Smile Pro and Silk. Like, what is your preference, Rupal ma'am and ma'am?
I
It's
have
like,
been using only Smile
you
Pro.
are, if I am owning a Mercedes or say a Maruti, and then if you ask me which car do you like the most, I would always say Maruti.
Yes.
I think each platform, as Dr. Sheetal rightly pointed out, has its own advantages and limitations. And I myself like Visumax the
Smile.
most because I have used that a lot. And I know every
Yeah.
nitty-gritty of that particular laser. So I think it's more of familiarity and it works really good in my hands. So I'm
Right.
very happy with that. But having said that, I would not say that the other platforms are bad or they are inferior or anything of that sort, because they already have a base on which they've built. So most of the platforms, like
True.
most excimer lasers today, are going to be very useful and almost at the same level. Uh, Maybe a year later, once the cumulative experience becomes a little better. Right now, because the other platforms are still in its infancy, sometimes you find limitations in visual recovery, but that
Right.
will get sorted out within a year, I think,
Yes.
once the cumulative experience comes in. And
Right.
at that time, then all the platforms are going to be equal.
Sheetal ma'am, what's your take on this? Have you, what all, what all bases have
Of
you
course.
tried?
So I have been using, I used Visumax 500 earlier for many years, and now I'm using 800
Okay.
since the past 5 years or so.
Yes, ma'am.
So definitely it is much improved now. So it's just 8 seconds laser. So
Yeah.
hardly any suction loss. I never had any suction loss. Earlier I was teaching trainees the whole algorithm of suction loss, ma'am. Now with 800, it's like I've never experienced it. So
Less action
this is
loss.
kind of, this is a big relief actually for new surgeons who may want to learn lenticle technologies. But of course, other technologies also have very good features. So it's not that any one laser is perfect. No
Right.
laser, I mean,
Right.
every laser has some or the other
Um,
limitations. This is why I took a lot of time to prepare those last slides. So just to, give you
it was a
a
wonderful
broader picture.
comparison, actually.
Yeah. So some lasers like the Zemer has the lowest energy, right?
Right.
Very smooth
Right. Yes.
overlapping pattern,
Yes.
which is not
Yes.
there with other lasers, right? So every laser has a strength and limitation. So the
Yes.
biconvex is with Elita. So, so we can't just say that any one laser is perfect. So yeah, every laser is good. And with the published results that you can see,
Hmm.
all the platforms, you can see at 6 months, they have like 96-97% seeing 6/6 or better, and very good safety. So that clearly
Correct.
shows that this is the data, published in JRS and reputed journals. So this is very encouraging actually. All
Right.
platforms are giving
People,
good results
it
and
also
are
says what nature
improving.
does for us,
So
what nature does for us,
yes, ma'am.
it also depicts that. Because in 6 months' time, nature also does whatever repairs it needs to be done.
Yes, ma'am.
Yeah, 6 months, of course. Yeah. Cornea also heals. Yeah.
Yeah,
Things
epithelium
improve by
covers
six
all the
months. Yeah. But of
small
course, we
irregularities
need
that are there.
more comparison studies.
But lenticule
Yes.
extraction procedures are here to
Early
stay.
outcome
That's for
studies,
sure.
comparison studies, one eye with one platform. Yes. Yes.
Yeah,
Ma'am,
that
Kritika,
may probably so. But I don't
Great.
really think we need to do even that, because each platform definitely gives good results. So they're all here to stay. And I think all refractive surgeons should seriously consider adopting this technology.
Yes, ma'am. Kritika had some doubts. Kritika, are you there? Do you want to ask them?
Yes, ma'am. I had a question.
Yes, please go ahead.
Is there any limit set for pupil size when we are planning on going for a laser refractive surgery? As in a set limit, like a number for pupil size, ma'am. Pupil diameter.
Sheetal, you want to answer that?
Maximum I have treated is, she's asking if there is a limit to pupil size
Hmm.
that we can treat with lenticular extraction.
Yes, ma'am.
So we don't like to go less than
Is there
5
any number?
millimeters
So
in
Less
any
than
what I
case.
have
5.5.
treated maximum is a 7 mm.
Yes. So minimum you cannot go down in any platforms, I think, to less than 5, because that would mean that you are making too small a zone and it would not be stable. It would also induce a lot of aberrations. So even in excimer lasers, you are not going to be able to go less than 5. So any corneal procedures, refractive, should not be done in too small a zone. Bigger the zone, better is the stability profile. On the higher side, you don't really need to go much higher than, say, 7. Ideally, in Indian pupils and all, 6.5 is usually sufficient. It's also because of the Stiles-Crawford effect that you don't need to do zones larger than the, or always matching the scotopic pupil size. So it is important to look at the scotopic pupil size, but you don't really need to make zones larger than 7. Also, there is limit in the cornea to be able to remove any tissue. Larger the zone, more is the tissue removal. So that would also limit you the amount of correction that you're going to do. So if there is too large a pupil and a large optical zone to be created for a very large refractive error to be treated, it's better to do a procedure like phakic IOL rather than going on the cornea.
Ma'am, there was another question, not about this class, ma'am, but since you're the master of circle scan as well, I had another question of for that. Ma'am, in a case where we have to decide on a redo procedure, which one would we prefer? Should we prefer a excimer laser or a circle scan?
So circle scan is something which converts the cap into a flap. But once you lift it as a flap, you need an excimer laser. So it is not either or.
Ma'am,
If you
trans
use a
PRK.
circle scan,
Yes, ma'am.
so trans PRK can be done, provided you have left a thick enough cap. Okay. But yet, when you do a trans PRK, you would need to use mitomycin, even if you're treating for a very small myopia, because the keratocytes are already active and excited. But if you are going to, if you have enough tissue left on the bed, then it's better to do a circle and extend the cap into a flap, open it, and do an excimer laser, and that would also do well. So the pain part you'll be able to avoid. Also this chance of getting a haze or regression. And for that 5-6 diopter of treatment, you gave the patient no pain. And now for that 1 or 0.75 diopter, if the patient has pain for 3 days, he'll curse you forever. On the other hand, if there is no tissue left on the bed or after the cap, then you can go on the cap as trans PRK.
Okay, ma'am. So the residual stromal bed, even for redo procedure, has to be 300, not more than, not less than 300 also.
Not less.
We should follow right now till we have more clarity about the biomechanics. So right now the understanding is that we should be leaving as much as we can.
As much as.
Okay, ma'am.
Kritika, do we have any more questions from the YouTube side or maybe?
Ma'am, no, ma'am, I don't find any questions on any OTT platforms.
Okay. I think, ma'am, we're done for the day. Thank you so much, Sheetal ma'am. Thank you so much, Rupal ma'am. It was such a nice discussion. The presentation was lovely. We understood a lot, and I think a lot of people are going to benefit from them.
Thank you, Shreya,
Thank you so
and
much.
thanks,
Thank
Sheetal,
you,
for such a
ma'am.
wonderful
Shreya.
presentation.
Thank you,
Bye
ma'am.
bye.
Bye bye, ma'am.
Learned so much always. Whenever I talk to you also, and every talk, every word of yours is gold. So having you see my presentation, comment on it, has made my day. Thank you so much, ma'am.
Thank you so much, ma'am.
Thanks.
Thank you, ma'am. Thank you, ma'am.
Bye bye, ma'am. Good night.
Bye bye. Good
Thank you,
night.
Ritika.